Hello, I'm Dr. Naveen Pamaraju, Associate Professor in the Department of Leukemia at MD Anderson Cancer Center. Today we'll be discussing moving beyond cytotoxic chemotherapy and the era of Tagraxofusp SL401. Tagraxofusp, or SL401, represents a novel targeted therapy specifically designed and directed to the IL-3 receptor alpha, also known as CD123. This is important because the CD123 entity is overexpressed in virtually 100% of patients with BPDCN, as well as many other hematologic cancers. Tagraxofusp, or SL401, is a novel targeted therapy that consists of a truncated diphtheria toxin payload fused to a human recombinant IL-3. This agent, Tagraxofusp, is notable in that it shows data specific to BPDCN with high levels of potency against BPDCN cells and model systems, both in vitro as well as in vivo. Now, in a previous phase 1 pilot study in which I was a part of, we published and showed major responses in 7 out of 9 patients treated, or 78%, which included 5 patients with complete remissions with only 1 cycle of the therapy drug, and this was published in Blood in 2014. Based on these encouraging results, we set out to design and conduct the first ever multi-cycle, prospective, multi-center study of Tagraxofusp, or SL401, for patients with blastic plasmacytoid dendritic cell neoplasm. Notably, these results were recently published in the New England Journal of Medicine in April of 2019, and I will share with you these updated results. First, this clinical trial was designed as 3 stages, all within the same trial infrastructure. As we walk through each of these stages, I will highlight the differences and similarities. In stage 1, or lead-in, this was conducted as a classic dose escalation, so-called 3+3 design, and included patients with BPDCN both in the frontline, 1L, and relapsed refractory prior therapy. Tagraxofusp, SL401, was given in incremental doses per the 3+3 design, starting at the low dose, 7 microgram per kilogram dosing, escalating up to 12 microgram per kilogram dosing. The infusion is given as an IV drug days 1 through 5, but over a 10-day window of a 21-day cycle. The key objective of the stage 1, of course, was to determine safety. Now, in the stage 2, or so-called expansion stage, again, both frontline and previously treated or relapsed refractory BPDCN patients were included. The study drug Tagraxofusp was given now as 12 microgram per kilogram, as even though a formal MTD was not reached in the stage 1, based on efficacy and safety, the investigators selected this dose to move forward as the phase 2 dose. The key objective now in the stage 2 for the first time is to formally define efficacy along with continuing to monitor closely for safety. Finally, a stage 3, or pivotal confirmatory stage, was designed. Importantly here, I want to focus that this was only highlighted and kept frontline treated patients with BPDCN at the 12 microgram target dose, and this was to confirm the efficacy seen in the stage 2, but focusing only on the frontline treated patients. At the bottom of the slide, you'll see select inclusion and exclusion criteria, and I want to walk you through those. In terms of inclusion criteria, the most notable is that the trial was open to patients 18 and over with a performance status by ECOG of 0 to 2. In terms of the usual adequate organ function required for most clinical trials, the one I will highlight to you the most will be the albumin number, as originally was listed as 3.0 to reflect the pilot study's results of capillary leak syndrome and fluid retention, and then quickly moved by investigator consensus early on to albumin level of 3.2. In terms of select exclusion criteria, fairly typical exclusion criteria is listed here, again, ruling out patients with clinically significant cardiopulmonary disease at baseline. 2 caveats were that to ensure ongoing access to Tagraxofusp, there was actually a stage 4 opened and enrolled for patients to give additional access even after the primary endpoints were met in the stage 3, and there were several patients treated in the pediatric setting in the so-called compassion care use setting. Let's look at the demographics on this phase 1, phase 2 trial that led to FDA approval. On the left, you'll see stages 1 and 2, the middle column stage 3, and the final column all 3 in aggregate. Focusing on the left, stages 1 and 2, we enrolled 32 patients. The median age of 72 up to an age of 84 indeed reflects what one would expect from the historical literature experience. The vast majority of patients were male, 81%, and importantly, over half the patients, 59%, were actually frontline treated patients, and only 41% were relapsed refractory. Let's look at the baseline sites of disease distribution. This again is in keeping with the historical expectation, with the vast majority of patients having skin involvement and approximately half with bone marrow and or extramedullary non-cutaneous involvement. Almost everybody on the trial ended up getting the target dose of 12 micrograms, so 29 out of these 32 patients. In the middle column, the stage 3 patients, again, I want to focus and highlight that these are only frontline treated patients, 13 patients, median age of 65 with a range up to 84, and of course, by definition, these patients were all frontline treated, 13 out of 13. Now, on the next slide, I'm going to show you the compartment measurements for designing and implementing some sort of a response tool. As in most rare diseases, there was no prospectively defined comprehensive response assessment, and so we put this forward for the sake of this clinical trial to be used for this trial and hopefully for other experiences moving forward. Because there's 3 sites of disease, skin, bone marrow, and lymph node, we use assessment tools borrowed from other major diseases and used in BPDCN. The first is the skin using the MSWAT tool. The second is AML bone marrow criteria, and the third is lymphoma-based imaging criteria for CT or PET-CT scan. Notably, patients on the clinical trial had blind biopsies at different points, including skin biopsies, even in the absence of grossly observable disease. And based on some of the results, you could have a scenario of no detectable disease, but still have some residual or microscopic skin disease of unclear origin. This was called the CRC, or clinical CR. Let's look at the safety and tolerability of Tagraxofusp. This slide is actually a comprehensive slide showing not only the patients with BPDCN treated at 12 microgram per kilogram per day, but actually a total of 114 patients, representing patients treated with the study drug even outside of this trial, so that we may better have a more comprehensive understanding of the safety and tolerability. As you take a look at this chart, 2 important items stand out. One is that there were no apparent so-called cumulative adverse events. That means that the majority of AEs that we saw were really restricted mainly to the first cycle, that the capillary leak syndrome, which we'll talk about in detail, really was also restricted to the first cycle and was managed appropriately and quickly with the mitigating features that we'll discuss. And if you look at the capillary leak syndrome incidence, you will see that it occurred at all grades, including death on study, representing the most serious and important side effect of Tagraxofusp administration. Let's talk about the capillary leak syndrome in greater detail, as this is of high importance and is listed on the FDA approval package insert as a so-called black box warning. When thinking about the capillary leak syndrome, there are at least 2 other modern-day drugs that have similar profiles. One is the so-called ONTAC, or Denlucan Difitox drug, which is an IL-2 receptor-directed therapy hitting CD25. This drug is approved in the cutaneous T-cell lymphoma setting, also carries a box warning for capillary leak syndrome, and in this experience for the clinical trials, capillary leak syndrome occurred in approximately 1/3 of the patients, and out of 76 patients, 1/3 needed hospitalization or major intervention to prevent a hospitalization. A second experience is that of moxetumomab, the CD22-directed cytotoxin, which is a first-in-class drug recently approved for relapsed refractory hairy cell leukemia. Yes, it showed a high overall response rate, but also carried a signal for possible capillary leak syndrome, including a life-threatening possibility. In the database of 129 patients with hairy cell leukemia treated with moxetumomab, capillary leak syndrome of grade 3 or 4 was noted in 1.6% and 2% respectively in these patient populations. As we get back to the Tagraxofusp clinical activity data, let us look and see how patients did in stages 1, 2, and 3. This will be a total of 42 patients who were treated at the 12 microgram per kilogram dosing. On the left, frontline patients, the middle column relapse refractory, and on the right, all patients together. Focusing on frontline treated patients first, 1L, among 29 patients, we reported a remarkable 90% overall response rate, of which the majority were complete remissions at 72%. Furthermore, there were 5 patients, or 17%, who experienced a partial remission, and approximately half the patients, or 13 out of 29, were able to be bridged to a stem cell transplant, remarkably the majority of these allogeneic transplant. Now let's look at the middle column together. These are in the relapsed refractory patients, a total of 13 treated on the study. This showed a 69% overall response rate, of which 38% were complete remissions. 4 patients experienced a partial response, and 1 patient was bridged to a stem cell transplant in this setting. Now we focus and highlight on the stage 3 patients treated with Tagraxofusp on the phase 1/2 clinical trial. And again, to remind you, these are patients treated at the target dose 12 microgram, but frontline only patients. Here in this pivotal confirmatory cohort, which met its primary endpoint, we reported a 54% rate of CR/CRc, 7 out of 13 patients, which exceeded the pre-specified statistical rate. Let's look at these responders in detail. On the left, the stage 3 responders. So again, among these 13 patients, we saw a 77% overall response rate, of which 54% were complete remissions, 3 patients with a partial response, and 6 of these patients bridged to an allogeneic stem cell transplant. On the right, we focus more on the stage 3 complete responders. Here, as you can see, the individual responses are shown in aggregate. For these patients achieving a best response of a complete remission, regardless of how high the bone marrow blasts were at baseline, these patients achieved a rapid reduction in their bone marrow blasts as well as skin lesions. To give you an idea of what the skin lesions look like in the clinic, a representative patient is shown here. This was a 70-year-old man treated with 1 cycle of SL-401 Tagraxofusp, and as you can see here, complete resolution of the skin lesions by the end of the first cycle. In terms of the bone marrow responses, one important thing to note is that among patients treated at the 12 microgram per kilogram dosing in all stages, in either frontline or relapse refractory, complete responders showed rapid reduction of the bone marrow blasts, often after 1 cycle of therapy, no matter how high the bone marrow blast started. This slide shows swimmer's plots. These allow us to look visually at the individual responses in aggregate. On the left is Tagraxofusp best response and treatment duration among stage 1 and 2 frontline treated patients only at the 12 microgram. As you can see from the graph, the majority of patients did indeed achieve a complete remission, as we discussed earlier, and many of these patients were able to be bridged to a transplant with ongoing responses even after the transplant date. On the right, the stage 3 patients in the frontline setting for 12 microgram dosing show a similar profile. On this slide, we detail the overall survival for the Tagraxofusp dataset. This focuses on the frontline treated patients with BPDCN at 12 microgram through all 3 stages, so a total of 29 patients. Importantly, as you can see, the median overall survival has not yet been reached, and there are many long-term survivors noted in the follow-up on this study. So in summary, for Tagraxofusp for patients with BPDCN, we show that BPDCN, a disease of historical rarity with poor outcomes and no standard of care, now has a drug that shows high response rates in a phase 1/2 clinical trial, including 90% overall response rate in the frontline setting and 69% in the relapsed refractory setting, with the majority of these responses being complete remissions. Furthermore, approximately half the patients in the frontline setting were able to be bridged to a stem cell transplant. And so based on these data, Tagraxofusp was approved by the FDA on December 21st, 2018 in both the frontline and relapsed refractory settings ages 2 and up, noting the black box warning of the capillary leak syndrome. And in addition to being the first targeted therapy for BPDCN, this agent represents the first in class of CD123 directed targeted therapies. Furthermore, the drug is being studied in multiple phase 1/2 clinical trials in additional malignancies. Thank you for your time and attention. Good day.